Hey, everybody, this is Eric Mishi, SAVE Executive Director, Suicide Awareness Voices of Education. And we are coming to the end of a day of incredible conversations that we've had with folks, ranging from discussions about the construction industry and what's being done with innovation by companies like Gardner Builders, conversations with Bob and Lynn Pofferl, who are suicide loss survivors who have taken their grief and turned that into hope by giving back to others, by trying to find meaning and purpose behind their loss. And we had a conversation with State Representative Kristen Bonner earlier today to talk about social media and the impact of social media platforms on kids' mental health and the Minnesota Kids Code. So every conversation we have had has been enlightening. It's provided us some additional insight into the work that people are doing on a local, state, and national level. And I'm excited about this conversation with Kelly Felton, who is the Minnesota State Suicide Prevention Taskforce Coordinator. Kelly, thanks for being with us today.
Thank you for the invitation. Happy to be here.
Did I get the title right?
Yes, I'm the State Suicide Prevention Coordinator, which includes coordinating the task force. Yes.
Okay, there we go. So I needed to put in both of those. So let's talk a little bit about kind of what your background is and talk a little bit about what the work is that you do with the Department of Health.
Yeah, I started with the Minnesota Department of Health almost 5 years ago. And prior to that, I was doing substance use and misuse prevention, both at the local level, but also at the regional level. And really fell in love with prevention there. And previous to that, I was a probation and parole officer up in northern Minnesota. So all of those experiences have really helped me in my current role as the state coordinator to kind of move things forward in a strategic and effective way across the state.
So we're going to come back to the parole officer role here, because there is an association with the incarcerated community and things like that related to mental health and suicide. But talk a little bit about, as the State Suicide Prevention Coordinator, what does that mean? What are the resources that you have at your disposal? And for folks who may not know that such a thing exists at all anywhere in state government, give us some insight into what that means.
Yeah, well, in Minnesota, we're really fortunate to be able to have a large team to do this work. Historically, this position in particular was a part-time position that did all suicide prevention across the state from that government lens. And now we have, close to 12 people on our team doing suicide prevention. So my role in particular on the team as a state suicide prevention coordinator is to really think about things very macro. And so I help with the writing and implementation of the state plan to ensure that we're doing what we said we're going to do. And then also a big piece of that is working with our community partners within the Suicide Prevention Taskforce, which is written into our state plan to help us do all of the strategies that we said we were going to do.
So as you describe that task force, you describe that work, what are the kind of things that are involved in putting together a suicide prevention plan on a statewide basis?
Yeah, we just finished our first year of implementation of our state plan. It is a 4-year plan, and we're very proud of all of the work that we did to get us to this point. A couple things: we wanted to be really active in saying we're not only going to put together a plan and have it sit on a shelf, but to put together a plan that truly is guiding our work. And for it to be guiding our work, we really wanted to make sure that we were listening to citizens from across the state. So we took a lot of time, that whole first 1 year of planning, to look at our epidemiological data to see who's most affected by suicidal experiences, to having focus groups and listening sessions, both with people that are most impacted, but also geographically. We wanted to make sure that we were talking to folks in northern Minnesota as well as in the metro, and to really hear like what's working, what's not working, and all of that really helped us guide to say, what are we going to do as a state for the next 4 years to try to start really getting people not only to save the lives, but to really figure out how do we help people thrive so that we're not just, looking at just that one measure. We really expanded this current plan to include more upstream prevention as well. So we are doing things that are including of mental health promotion, early intervention. We don't have to wait until crisis to do suicide prevention. So it's across that entire continuum. And of course, also figuring out how we can better support those that are last survivors to suicide as well.
So it's interesting. So you talk about that in the context of kind of different parts of the state. And, earlier today we had a conversation with Monica, who you know, who is a rural mental health behavioral specialist, and talked about the unique challenges facing rural communities and not just in Minnesota, really across the country. So for folks, again, who are not, quote, experts in this space, there's clearly got to be differences in terms of access to resources, demographic profiles, how you address and communicate. That it's not just a one size fits all approach.
Right. Yeah, and that's really built into our plan to really say we need to be working at the local level to be able to do this work. When we think about proactive prevention, it should be where people are living and working and playing. And so one of the things that we have written into the plan is how do we build capacity for communities to be able to do this hard work? The reality is we are all doing suicide prevention, but we don't maybe necessarily call it suicide prevention. And so really starting at the community level to say what's already happening. There's such good work happening at local levels, whether that is rural or in the metro. So it's starting to learn how are our systems working together, amplifying the good work that we already have. So that if you're in a rural community, it might be less resources, right, than if you're in the metro. And so, but starting with saying what resources do we have, and really as a community identify those gaps or determine ways that we can work better together to get people the help that they need. And so a lot of what we have in our state plan is really geared towards how do we help community do this work, because we know that that's where it's going to be most effective, while we're also doing things at the state level too.
So you've been doing this now for 5 years. Mm-hmm. What's different today in this conversation and this work than what it was when you started it 5 years ago?
Yeah, and I think that this is just an evolution of our field in suicide prevention as well. But when I first started within the Department of Health, we spent a lot of time in that crisis intervention space, doing a lot of training on how to identify people that are suicidal, how to ask them if they're suicidal, and then get them to the care that they need. That continues, Eric, 100%. We're still doing that training. We still need to make sure we're having conversations. But we've really expanded the way that we talk about it to really say, we all have mental health, right? We've spent a lot of energy in teaching people how to talk about suicide, but in society, some people don't even like to talk about mental health. So sometimes we got to go up a little bit, up that stream, if you will, to say, if we can't talk about mental health, well, there's no way we're going to talk about suicide. So really just starting to normalize this conversation has been a big push coming out of our unit to say, hey, we all have mental health. We all have different adversities that happen in our lives, and we can talk about it, knowing that connection is such a protective factor for suicidality that we need to be able to have those conversations and understand that not everybody needs a mental health practitioner. It might be that the root of their problems might be around finances. Well, then let's help them get finances, right? We don't have to always continue to send people to formal care unless that's what they need. And there are other things that we can be doing so we don't have to wait till that moment of crisis.
Yeah, and I think that's an important point and it also kind of comes back to that role that each one of us plays, right? Nobody has to be an expert in suicide prevention, right? You just need to be able to know how to ask somebody a question. You also have to have a little bit of knowledge of if somebody you're asking, if they're thinking of killing themselves and they tell you yes, what do you do with that information? That doesn't require you to have a doctorate degree. It doesn't require a medical degree. You don't have to be an EMS or a first responder. You just simply have to be willing to have that conversation. And then the other part of that, to your point, is that not every conversation needs to lead to going to a mental health professional. It may, and we shouldn't avoid that. But understanding that there are other risk factors here that are predictors of suicide are not all directly related to a mental health diagnosis.
Right. Exactly.
And so how do you, in the work that you do and in the work that you share with organizations like SAVE and others who are involved in this, how does that kind of translate out into the broader Minnesota community?
Yeah. I can tell you, Eric, that with this evolution of where we're going, it is a little bit of a different approach, but we have now 22 community coalitions funded across the state to be able to take some time to really dig into saying, as a community, we need to come together to work on this. So developing community coalitions from different multi-sectors, right? So you have law enforcement, you maybe have faith or cultural community, the schools, whoever that might be, where people live, work, and play, right? All of those different organizations and systems we live in. And then having them really dive into seeing what's happening within the lives of people that are having suicidal thoughts, maybe attempts and or deaths, and really kind of looking at that local data, which oftentimes when we think about suicide prevention, we're thinking about crisis and we're thinking about one-on-one, where this approach is saying there might be other things we can be doing to get our systems to work better together, to understand that if people don't have transportation, that puts different stressors on us. If people don't have good connection within their social space, what does that mean? Is there isolation happening? So really trying to understand what's happening in the lives of their community as a whole, and then putting together a plan to say, what can we do to address that? So it's a very different approach than maybe what we automatically think about when we think about suicide prevention. And it's a lot more upstream, right? Like we're addressing things to say, maybe people need coping skills. Maybe people, maybe it is normalizing the conversation around mental health and suicide as a community. Communities still don't talk about it, right? So that can be something that communities can do, but also really making sure that we're looking at policies and systems to know that's how we're going to make change that's sustainable and that we can really do some really good work in this area. And it doesn't cost a lot of money. And I think that communities have sometimes what they need, but we're really bad at, how do I say this? Resource rich, collaboration poor is kind of how I say it, of sometimes we have a lot of resources, but we get into our silos or we get into turf war between whatever it is that we're doing of that's not mine, that's yours. And people are getting lost in that. And so just really trying to figure out what does that look like at the local level.
So for folks that are watching and hearing and listening to this, explain a little bit about when we talk about suicide prevention and the difference between kind of traditional suicide prevention and when we talk about what does it mean when we say we're talking about upstream approaches?
Yeah. Really what I think about, apologies. What I think about is it's working across the social ecological model. We all live as individuals. We have our own things that we can be doing, but we also live in relationships and we live within society. And sometimes when the analogy is that we're pulling people from the river, right? So if you think about a river, and you think about there's someone floating in the river, I'm going to pull them out. I'm going to pull them out if they're in crisis, right? And really taking that time to go upstream. When I say that, meaning like, do I go in and just save them? Or another could be like intervention. Do I go in and teach them how to swim, coping skills, teaching them what to do? Or do I go up and see why people are falling in the river to begin with? What is it? Is it our policies? Is it, in this case, like the scenario that a lot of people use is like, is there a cliff that people are falling over, right? Then let's build a bridge so that people, or a railing so people don't fall in. So like when we think about that concept, it's continuing to say, if someone's in crisis, what's causing that? Because the barrier that I think sometimes we do is like we save them, right, through that intervention, but then we're not addressing the root cause of what's causing those stressors and the things that are happening in that person's life. So it's really about continuing to go upstream to say, let's address that then, to make sure that they have what they need to succeed, or whatever that looks like for them.
So there's a lot of talk about this term called social determinants of health, right? And so I'm assuming that when we talk about upstream, it's addressing some of those social determinants, right? Economic factors and kind of where you live and kind of what your life is like and what your access is to resources and things like that. So there was just a study released, I think it was by the CDC in the last 3 or 4 days, that talks about, people's rates of suicide are lower in areas that have access to mental health and kind of addressing those social determinants of health, which if you spend 2 seconds thinking about it, you'd go like, aha, that makes absolute sense, right? And yet, even though it makes absolute sense, if it was that easy, you and I wouldn't have these jobs.
Yeah, absolutely. I think it's a conversation that we're having with the Suicide Prevention Taskforce right now is, what does it mean to address social determinants of health when we're working on suicide prevention? And we don't know, quite honestly, Eric, because these are big things, right? We're talking about housing, and we're talking about food, and we're talking about jobs, and we're talking about these really large topics. And the questions that we're like sitting with is saying, like, what does that mean? Does that mean that we uplift the work that's already being done in that area? Because I don't know anything about housing, right? As a suicide prevention person, but I know the effects of that. It's like, what does that look like? And at the local level, are those things being connected? Knowing that if you're working on housing, you're also helping the individuals in our community with their mental health and suicide prevention. And so we are definitely in the midst of that conversation. I think nationally, we're having those conversations as well. But we grapple with it a little bit because they are big things. But like you said, but it's also like of course, right? If we don't have our basic needs met, of course we're going to have stressors, right? And we're going to have all of these things that build off of one another. So definitely on our radar for conversation and continued conversation. But I think that we're just all kind of saying, like, what does that mean? What does that look like?
Yeah, it's fascinating. We were at the American Association of Suicidology National Conference earlier this year, and one of the conversations was obviously around this whole concept of social determinants of health and the concept of a minimum basic income and what impact that had on a family's mental health when there was the ability to focus on things other than how you're going to pay your bills and how are you going to pay your rent or your mortgage and put food on the table. And again, as you think about it as just a single individual, right, sitting at your own kitchen table, your state of mind is much better when those are things that you're not worrying about. Absolutely. But if your very existence is tied to, do I have enough money to pay this bill? Do I have enough resources to do this? And then you think about different professions and occupations. Again, go back to farmers and rural communities where those stressors are there 24/7, 365, days a year. And it becomes even more important to be looking at what do we do to deal with the upstream issues here, rather than simply looking at the downstream aspect of this.
Yeah. I think it comes back to another one of our core pieces of our work is really continuing to think about holistic wellness. I think sometimes we put mental health in a box of like we can't cope our way out of problems that we're having, right? Like we can use our coping skills to get us through, but that alone isn't going to solve the problems. And so we really utilize the 8 dimensions of wellness, which is a model through SAMHSA, the Substance Abuse Mental Health Services Administration. And it really just talks about like there's so many things that are contributing, which includes those social determinants of health, right? It's our financial health, our physical health, our emotional wellness, our jobs, right? Like our occupations, our social wellness, those 8 dimensions. That's how we got to be thinking about even suicide prevention, because those look different and we're complicated beings, right? It's going to look different for each of us as individuals, but it allows for us to think about like, yeah, they do interact, right? And as someone, because we all have mental health, I know if one of my dimensions isn't working well and things are not running as smoothly as I'd like, it's going to affect all of my other dimensions of my health too. So just continuing to kind of think about it more broadly, I think is going to be the direction that we're going to continue to go.
Yeah. So as you think about the work that you're doing now and the work that you focus on in the future, where do you think the greatest opportunities lie for making a dent in this space?
Yeah. I think if you ask anybody, they're going to have a different answer for you, right? I think for me, I know the power in community. And so, it depends on kind of your role within the space of suicide prevention. Like you've said, we all have a role. As an individual, I have a role. As a mom, I have a role. But our communities, I think for me personally, the community approach is really going to put that web of support around individuals that are living in that community. And community is defined by however the community defines it, right? Like it might be a school district, it might be a block within a community. That's going to be different, but knowing like we can support one another, our systems can be set up to support one another, to give us what we need to be the healthiest that we want, like our community to be. If our community is healthy, our individuals can be healthy too.
Yeah. We had, as you know, the most recent, the 3rd iteration of the national strategy prevention was unveiled in DC over the summer. And one of the component parts, and we had a conversation, with one of the architects of that this week from the CDC, and I asked the question. I said, "What is the most important part of that strategy and plan?" I said, "What is it that makes it live, succeed or fail if it doesn't happen?" And the comment that she came back with time and time again was getting the community involved. That if you don't get and defining community really is broad, right? So community is nonprofit organizations like SAVE and other groups, right? Community is the faith community, it's political leaders, it's the business community. So community is a pretty wide swath definition,
right?
And so as you think about that, it takes a lot of work to quote get that community all on the same page. So how do you do all that, and how do you get it done easily and quickly, or do you?
You can't. I think this is going to take time. It's really about finding the right people to take the lead, finding the people. You're going to have somebody take the lead, whether that's an organization or an individual that says, yes, I'd be happy to coordinate it. We have resources through Some of the work that we do with our regional coordinators around the state, that we have people that can help do this community approach too. So you're not in it alone. We have the resources. We can teach you the process of what that can look like. And, you know, like I said before, like really good suicide prevention work doesn't cost a lot of money. It's really just like amplifying what you already have and getting our systems to work better together so that we do have that web of support for people that need help, right? Whatever level of the river someone's in, right? Of really just figuring out what we can do proactively, but also continuing to help those that are in need, whether that's early intervention or crisis intervention, or of course after death by suicide as well.
And so we talked a little bit about, you know, maybe what are the greatest opportunities. So what are the greatest obstacles or challenges that you see to having success in this area?
Yeah, I think that's a really great question. What we know when we think about this community approach is that it's hard work. This is not something that's going to happen overnight, and we're not going to see the changes for up to 5 to 10 years on those bigger numbers. And I think that that's really hard when we can't see that immediate change that many of us can see with other things in our lives. And so we need people that have that passion, that are willing to take that lead. The barrier comes to like, I have all of this data, or I know what's happening in my community, but I don't know what to do with it. And what we have really built into our state plan and work with these wonderful people across the state, our regional coordinators that can help figure out what that means. And we have a group of folks that can really help you, like kind of walk alongside you to say, like, what is happening in your community? What do we do when we find that out? What strategies are going to be most effective for your community to consider? The hard part is that we can't just do one strategy too. I think that complex issues such as suicide need complex solutions, and it's not an easy fix, if you will. So I think really just being patient is, if I were to give any advice, be patient and build those relationships within your community, because we're in it for the long haul. But it's not only going to help with suicide, it'll help with many other things that communities want to be working on as well.
Yeah, it's interesting. I was part of a conversation with a group maybe a month or so ago, and we're getting ready for a strategic planning event in a couple of months. And one of the comments was made is, you know, we need to have somebody come in and talk about, you know, what's the consensus on what the you know, what everybody thinks about what's the solution to this. And I kind of chuckled and I said, do you really think that there's anybody that's going to come to the table and say there's a consensus on what all the solutions are? I said, we'll be here, you know, until the cows come home. And it's interesting. And there's a book by Craig Bryan that's called Rethinking Suicide, where it kind of calls out some of what has been our conventional wisdom and thoughts about suicide prevention. And he comes back time and time again to this issue of, we really need to start focusing as much, if not more, on the upstream piece of this conversation. And that, you know, where our focus so long has been on that kind of very direct, what do we got to do to protect, you know, stop that one suicide, which has still got to happen, as you said, right? You still got to focus on that. But we also have to recognize that those broader social, cultural, socioeconomic issues that are out there that are created some of this crises have got to be addressed if we're going to have any hope of success at all.
Absolutely.
So
again, like I said, hard work, but I know the power of community and it can work.
I agree with that. And I also told you at the beginning of this conversation, this half hour is going to go lightning fast, like a Minnesota summer. We're coming to the end of it. And so as we kind of end this conversation, and each conversation we've had this week, I've asked the folks that we've talked to kind of end the conversation with some kind of piece of wisdom or advice or thoughts that are hopeful that people can think about and know that there are better days ahead here.
Yeah. I think this work, just like I just said to Eric, this work is hard, but it comes back to communities coming together and building those relationships. And there's so much power in community and us collectively saying, we want to take care of our own, and we know that there's things that we can do. So I just encourage communities to continue to think, like, how can we do this and get those players at the table?
Well spoken, and thank you for the hard work that you do. Your leadership, it makes a difference. It makes an impact. We're grateful to be able to have an opportunity to work with you and collaborate with you, and know that every single day your team is working hard to try to go out there and figure out a way we can help prevent suicide and save lives. So thank you for all you do, and look forward to chatting again.
All right. Thank you for the opportunity, Eric. I appreciate it.
Thanks. Yeah, have a great day.
Yep, you too.